Okay, cool. So you guys saw the schedule. I don't know, hopefully somebody logs on here and it's actually working. So we kind of start the first month here with like some basic mechanics stuff. So I'm going to talk about this is mostly pertinent anatomy. And then I'm also going to go through my physical exam for the shoulder, which you've seen a little bit, but again, just some pearls so we kind of have an idea of how we go through things. Anyway, so anatomy, some biomechanics, and then we'll do physical exam stuff. So shoulder, some of the stuff's pretty obvious, but these are also things to like kind of keep in mind, I guess, as you're going through. I think I just saw. So, hey, we got a recording.
Yeah.
Yeah, and look at this. It's like this.
Ooh, I like it.
I don't know how to stop the recording.
Oh,
looking like this. Well, I feel like it's not actually recording with the here.
You're using Zoom?
No, it's Teams.
I know how to do it in Zoom.
Yeah. It's this one. I clicked something. It was a terrible idea.
Is anyone attending remotely?
No. But I did something here that like here, see, it's got this now. Whatever, we're gonna go with this.
I like it.
It's pretty awesome. Okay. Anyways, so things to keep in mind. Most mobile joint in the human body, and this is something that plays a role in a lot of pathology around the shoulder as well. Lots of different muscles around the shoulder that all act in synergy to help produce motion. And then obviously it's the number one most awesome joint in the body. So bony anatomy, the four parts of the proximal humerus, originally described by Codman. So these are all based on the different ossification centers in the proximal humerus, and obviously become a role or have a role in proximal humeral fractures. Some of the general bony anatomy here, I don't want to go into a ton of numbers so that you guys can all forget them, but inclination on average is about 135, but it does vary from 125 to 145. This is a little bit of a tighter margin. It's actually probably, I don't know, like 90+% are within the 128 to like 138, 140. The bigger variation comes in retroversion. So on average, it's about 30 is what we're taught. Depends on the study that you look at. But I mean, there's some studies that show 0 degrees of retroversion to like plus 50 degrees of retroversion. This becomes plays a bigger role in reconstructing proximal humerus fractures to some degree, but also with arthroplasty, either trying to recreate native anatomy versus, setting it at 30 degrees if you're talking about a reverse or something like that. So the scapula, I'm going to go through this relatively quickly. Scapula has a couple of different bony structures here. Superior angle plays a role when you're talking about scapulothoracic bursitis or snapping scapula, that sort of thing. The scapular notch, it's where the suprascapular nerve comes into the shoulder. Coracoid process obviously is where the conjoined tendon attaches, and then we'll kind of breeze through this a little bit. So when we're talking about shoulder motion overall, and I'll go through this a little bit more in some of the later slides, it's important to know that there are multiple bones and joints that are all moving in concert. And this starts with the sternoclavicular joint, the acromioclavicular joint, which are the two bony, true joints that connect the shoulder girdle to the body. Then also the scapulothoracic joint. And as you move the shoulder, the scapula moves as well as the glenohumeral joint. Like I said, we'll go through this a little bit more later on. Vascular anatomy, this is like, I don't know if this is still tested on like OIT stuff, but this was always tested when I was going through. But there's basically the anterior and the posterior circumflex humeral vessels that supply the majority, about 90+% of the humeral head from a vascular anatomy standpoint. It seems like it's probably predominantly from the posterior circumflex humeral vessels. The reason this is important really from like a shoulder surgery standpoint is, number one, it has a role with fractures. So if you have a short medial hinge, comminution of the calcar, you've got a higher likelihood of injuring one of these vessels and going on to AVN, the proximal humerus. The other reason this is important is we get kind of used to, I mean, the vast majority of open shoulder stuff that you see is arthroplasty, and then you get used to coagulating these vessels. You should not be coagulating these vessels unless you're doing an arthroplasty procedure. If that makes sense, at least the anterior circumflex humeral vessels. So the rotator cuff, this is really probably the most, I don't know, important part of the shoulder as far as like understanding shoulder function, motion, stability, that sort of thing. From a basic standpoint, there's the 4 rotator cuff muscles that attach to the greater tuberosity and then the lesser tuberosity, with the rotator interval in between the subscapularis and supraspinatus. The reason this is important, and again, I think you guys probably understand this, but the rotator cuff, if you add it all up, is a large muscle. If you look at the cross-sectional volume of the rotator cuff, and its primary role as a stabilizer of the shoulder joint. It does help with some initiation of range of motion and function, but you have to think about it as a stabilizer of the shoulder joint. And when you have rotator cuff tears, deficiencies, you know, nerve palsies that are affecting certain rotator cuff muscles, you have to think about how that's going to affect the balancing of the shoulder joint, because that's the primary role of the rotator cuff as this, you know, the force couple, right? So it helps keep the humeral head centered on the glenoid so that all the big muscles around the shoulder can do the work, the deltoid, the pec, the lat, all that kind of stuff. So when you're thinking about pathology, you really have to consider it in that fashion. And that's also where like tendon transfers and that sort of stuff comes in. You're thinking about how to make up for the deficiency of what's in there and what it's doing to stabilize the shoulder joint. This shows it to some degree. I think this is from Matson, a Matson paper at some point, if I remember right. But anyways, this is really looking at the progression of like cuff tear arthropathy, pseudoparalysis, that sort of thing. So as you lose the net rotator cuff force of keeping the ball centered on the socket, the pull of the deltoid will start to overcome that pressure, and it'll pull the ball superiorly, as opposed to rotating the humerus up when you lose that pivot point or that hinge. And that's why reverse shoulder replacements work, because you create a constrained pivot point for the shoulder to move when the deltoid fires.
Just real quick.
Yeah.
Go back one picture. I hate this picture.
Yeah, I know.
This picture is so bad because it looks like the supraspinatus is pulling down. The supraspinatus does not pull down, it pulls up. The infraspinatus and the subscapularis pull down. Yeah,
that's a very good point. The supraspinatus you probably don't need at all for shoulder elevation. I mean, I don't know if you would agree with that, but it's really the
very good evidence that the whole thing is master. There's no proximal elevation that only occurs once it progresses to either the subscapularis.
And it's the balance of those two muscles. So if you have a complete rupture of a subscapularis, you know, anyways, like Peter said. But you're right. This is not a very good picture. It's an old picture. But as you start to progress your rotator cuff tear to involve the infraspinatus or the subscapularis, then you lose that centering motion of the humeral head on the glenoid, and it starts to migrate superiorly. As kind of shown here. So this kind of brings us into pseudoparalysis. I wanted to talk about this briefly because this is a term that's thrown around a lot, and there's a couple different definitions for this. You know, I think probably the most widely accepted definition is less than 90 degrees of active forward elevation with maintenance of passive, complete normal passive forward elevation, and then no nerve injury. Personally, I don't love that. I don't know how you feel about this, Dr. Chalmers, but personally, pseudoparalysis to me is when you try to raise your shoulder, you don't you don't pivot the glenohumeral joint at all. And that's like true pseudoparalysis. And that's where the rotator cuff tear is large enough that the head is not centered on the glenoid and you lose that force coupled motion. So, if somebody's able to go like this, that's really not pseudoparalysis. True pseudoparalysis will progress onto anterosuperior escape and that sort of thing. This is important. Another important thing with this is when you're seeing somebody and you say, oh, they fell yesterday and they can't raise their arm anymore. Is that true pseudoparalysis? I guess maybe it is, but sometimes pain is inhibiting it, that sort of thing. So when you see these kind of patients, doesn't mean you can't inject them. It doesn't mean you have to go straight to reverse necessarily. You can inject them, give them some time, that sort of thing. But true pseudoparalysis is very difficult to fix without a reverse shoulder arthroplasty to some degree. So rotator cuff insertion here, this again plays a little bit more of a role when you're reconstructing the rotator cuff or repairing the rotator cuff. The reason I put this on here, you can see this on these cadaveric dissections here, but the footprint of the supraspinatus is it's really this kind of, I guess it's technically a trapezoid, but it's really more triangular, right? So there's a wider amount of the footprint at the articular margin, and then it becomes narrower as you go laterally. And the infraspinatus footprint and teres footprint kind of take up that area. And you'll see this sometimes when you have like an isolated supraspinatus rupture. It'll rupture off and the entire infraspinatus will still be there attached. And it'll be covering a lot of that footprint. And you're kind of trying to figure out what you're looking at here. And that's why you can see that with an isolated supraspinatus rupture. You can see that, especially that one on the top, infraspinatus tendon. This is what you see sometimes. This kind of comes around. So if this is intact, you don't want to take this down just to repair your supraspinatus because you're taking down some intact infraspinatus. That makes sense. And then subscapularis, there's the tendinous portion, which is kind of the top three, the purple, orange, and red on the left. And then the muscular portion is farther distal. So, if you're doing a peel, osteotomy, that sort of thing for glenoid exposure, you have to understand that there's a muscular portion and the tendinous portion. And that's why, for me, when I'm repairing this in the end, I take an extra step to go find that muscular portion and try to repair that as well. Keep moving. So a couple of important nerves around the shoulder. So the axillary nerve is extremely important in shoulder surgery, especially open shoulder surgery, but shoulder surgery in general. It powers the deltoid, which is probably the most important muscle around the shoulder. Understanding the course of this is sort of half of the battle of feeling comfortable operating around the shoulder. So, some of the stuff you remember from anatomy, but so posterior cord is posterior to the axillary artery, but so the posterior cord is kind of running over the anterior aspect of the subscapularis deep to the conjoint tendon and the pec minor at that level. Then as it comes down, it'll branch into radial nerve and then axillary nerve. And then axillary nerve will go through the quadrangular space there. So the quadrangular space, triangular interval, all those are windows where nerves or blood vessels are leaving the axilla into different compartments of the shoulder, right? So it's one of those things that probably don't have to remember that it's the quadrangular space or whatever, but that's as the nerve leaves the axilla. So it leaves the axilla in the quadrangular space there, and then it'll rotate around the kind of the inferior aspect of the glenohumeral joint. So if you're doing capsular release, that sort of thing, you have to watch out for that over the inferior aspect as you're coming around. And then as it sort of exits the quadrangular space, it splits into anterior and posterior divisions. The posterior division will go to the posterior head of the deltoid and the teres minor. It'll have branches that kind of go off there. And then the end of that one will become the sensory nerve that comes around. So sometimes, and then the anterior division will go to the anterior and middle deltoid head. So if you're checking somebody's exam, that's why it's important to actually check all three heads of the deltoid, because if you have an isolated anterior branch injury, that will present a little bit different than an isolated posterior branch injury. So for example, you can have intact sensation and be firing your posterior deltoid, but then the anterior and middle heads are out. That's obviously still very important. And then where this is applicable for surgery is how to find it if you need to. and you basically can go underneath the conjoint tendon on top of the axillary, or sorry, the subscapularis. I mean, we do this all the time when we feel back there, but that's the easiest place to find it. If you're coming from a posterior approach, you can find it in the quadrangular space as well. Radial nerve, I think sometimes this gets forgotten, but you really have to keep this in mind, especially as you're doing larger approaches. The course of the radial nerve, again, posterior cord, and then it'll come anterior to the latissimus, and then it'll leave the axilla in the triangular space, so basically underneath the latissimus, and then it'll enter the spiral groove around the posterior aspect of the humerus. You can find the radial nerve there. An easier place to find it is distal in the arm. Distal in the arm. So as it courses around, it'll pierce the lateral intermuscular septum, and then it'll basically come in the interval between brachialis, brachioradialis. And you can dissect and find that just above the elbow here, and then trace it back proximally. That's if I have a big case, humeral shaft, whatever, something like that, where I'm going to be putting in cerclage cables or something like that distally. I'll a lot of times just extend my incision down, find the radial nerve there, and force it, trace it back so we know where it is. These are some of those anatomic numbers. Doesn't really pertain too much for the shoulder. So suprascapular nerve, this does play a role in shoulder pathology, and it's one of those things that you really have to kind of keep in the back of your mind with some of these people with mirrored weakness or pain or something like that in the shoulder. So this is off the superior trunk. There's two main compressions, really only two compression sites here. So the suprascapular notch, that can be from an ossified suprascapular or transverse scapular ligament, or compression there, or a cyst or a tumor or something like that. And then the spinal glenoid notch. As it comes through the suprascapular notch, it innervates the supraspinatus, and then it courses around the spinal glenoid notch and innervates the infraspinatus. And you can have a cyst or something like that from a labral tear that can push on that. The other thing I think that's interesting here is the suprascapular nerve has a pretty significant contribution to innervation of the glenohumeral joint. When people are doing like an RFA or something like that, they will a lot of times block the suprascapular nerve to see how much pain relief somebody's getting in the shoulder joint. So this is for your young patient with arthritis, your old patient that doesn't want surgery or can't have surgery. It's something to keep in mind. That, along with the axillary nerve, has some contributions there as well. So shoulder stability, yeah. So you might know better than me, but what they'll do a lot of the times, so you don't want to hit the motor part, right? So there's a sensory branch that will come off, and they will use an ultrasound to find the suprascapular nerve, and then basically start to course out laterally until they're not feeling muscle firing, essentially. And then that's the articular branch. I don't know. I've never actually seen it. That's how I've had it described to me before.
To go back one picture, my understanding is that if you look at that picture, it's just the anterior to there. There's this area of the nerve between the suprascapular and spinal glenoid notches, where the nerve has arborizations, what we did laterally, meaning that's what it's muscle and laterally these articular branches. So I've been told that they don't find the nerve. What they do is they find the joint.
Oh, interesting.
That space through the visors, and that they basically do kind of this area.
So Monson told me he finds the nerve, and then he will go lateral from the nerve to the point where he's not feeling the nerve firing, and then it's probably in that same area. I don't know. I mean, this is like in passing. I've never actually seen it. Maybe right. Maybe he starts there and then he does stim. Yeah. They only do suprascapular nerve branches though, right? They're not going, or do they go posterior to the joint as well?
Well, they
and get axillary branches.
Yes. My understanding is it's just superior, and it's described as an articular branch. It's a relation of articular branches of the nerve. There's multiple.
It's an option though. I mean, it does work. I've seen a couple people with it, so it's something to keep in mind. I'm not going to go through this in too much detail because this will be talked about later on when we go through instability stuff. But static stabilizer, the humeral head. So there's the glenoid and humeral head bone, and then there's labrum and cartilage, which I guess the one thing I want to mention here. So the hyaline cartilage in the center of the glenoid is very narrow. So that area of the cartilage is stiff. And then as you go out more peripherally, the cartilage becomes thicker, and then you get into the labrum. So the compliance increases, which allows for some motion in the shoulder while maintaining your negative pressure, suction cup effect. Then there's the glenohumeral ligaments, superior, medial and inferior, and then the coracoacromial arch. Dynamic stabilizers, rotator cuff, and then extrinsic muscles as well. This picture I think is interesting. So we see this. We kind of open up the rotator interval when we're doing capsule releases, subscap repairs sometimes, or obviously open surgery. And there's a couple of discrete structures in there. So there's the coracohumeral ligament, which attaches from the base of the coracoid out to the sort of superior aspect of the less tuberosity and bicipital groove. And then it sort of kind of fans around and attaches into the transverse humeral ligament as well. So when you're doing like an open approach, this is why I have you bovie down on the base of the coracoid to release any residual coracohumeral ligament there. And then there's also the superior glenohumeral ligament, which goes from the glenoid and kind of comes out and fans around and helps reinforce the biceps pulley and that sort of thing. So they're technically discrete structures in there, but it's important to know that like if you don't release it on either side, you're still going to have some tightness in the shoulder. So the scapula, I still don't really understand the scapula very well, but there's a couple different layers of muscles here. So on the left is this kind of superficial layer, which is the trapezius, the latissimus. And so the latissimus doesn't really attach to the scapula, but it sort of creates this like hammock effect on the inferior margin, as you can kind of see on that picture. And then obviously the trapezius attaches to the scapular spine, so a little bit more superficially. Then there's kind of the middle layer, which are the rhomboids and the lead over scapula, subscapularis, rotator cuff, that sort of thing. Then the deep layer being the serratus anterior, I guess subscapularis, rotator cuff is the deep layer. This obviously becomes an issue with scapular winging. I'm not going to go into this. We actually have another talk on this later in the year as well, but issues with the serratus anterior causes medial winging. Issues with the trapezius causes lateral winging, as you kind of see here. So shoulder mechanics, kind of real quickly here. This is Heath's lab, biomechanic, the arm in action here. Pretty awesome. But anyways, so when you're doing overhead reach, so there's a couple different phases here. So as you start, you're actually really starting to tilt the scapula, and then you start to rotate through the sternoclavicular joint. And then basically the entire clavicle starts to rotate, and the glenohumeral joint will start after about, I think it's like 15 degrees or so. So like when you're reaching way up, the initial part is really predominantly through the sternoclavicular joint and the scapulothoracic joint. Then as you get to these higher degrees of motion, you start to have more motion through the glenohumeral joint. And the overall motion for that is about 2/3 through the glenohumeral joint, 1/3 through the scapulothoracic joint. This is just showing muscle recruitment using an EMG as you start to move the shoulder in different planes. Don't feel like you have to look through all this. Basically, what this is saying is it doesn't really matter how you're moving your shoulder. Your rotator cuff is firing to help keep the head centered on the glenoid. And then your deltoid is almost always firing as well in concert with this. And then as you do certain motions, you can kind of see on here with like abduction, adduction, extension, the latissimus is firing with adduction and internal rotation. The pec major is firing. So those sort of work in concert. And then, so glenohumeral ligaments, kind of talked about these briefly. So superior glenohumeral ligaments, so this attaches from kind of the superior glenoid, similar to where essentially the biceps is attaching, long head biceps, and then it fans out and then attaches laterally. It's as far as stability in the shoulder, due to its position, it doesn't have a real significant role. in stability. It's more helps with stability and adduction, and also with flexion and extension. As you get to the middle glenohumeral ligament at 45 degrees, that's where it's tight. It helps prevent anterior translation and external rotation. Inferior glenohumeral ligaments are your primary static stabilizers when we're talking about the glenohumeral ligaments as far as instability goes. So there's an anterior and a posterior band, and they kind of, I don't have a great picture of this, but they sort of form this hammock. So there's the anterior band that will come and attach sort of between, like, depending on which shoulder you're at, like 2 o'clock to 4 o'clock, and on the glenoid side, and then the posterior band will be opposite that, from 7 o'clock to 9 o'clock. And then in between, there's kind of the axillary pouch, or the hammock there. So depending on the position that you're in, so if you're in 90 degrees of abduction, as you go into external rotation, you tighten the anterior band, and internal rotation, you tighten the posterior band. This is important when you're doing reconstructions, obviously. So there's like agal lesions where the ligaments will rupture off of the humeral side. It's also important, like, Romeo talks about this too, but there's two ends to these ligaments. So if you're looking to kind of boost your stability, you can put that 7 o'clock anchor in there, just up the posterior, to tighten that posterior band of the inferior glenohumeral ligament as well. But I don't know if you have anything further to say about those.
Yeah, I mean, I think the additional things are that you can think about the capsule of the shoulder kind of like a towel. Like, have you ever wrung out a towel, or when you squeeze, like when you wring the towel out, your hands get closer together? The same is true of the capsule of the humerus, that like when you rotate, you have less motion within it. So this is the reason why, like, when you fully elevate, you have less rotational motion than when you're in full adduction. So you have to think about the capsule is restricted at the end ranges. And the other thing to think, which I think is really important, is that when you see this drawn out in the book, it draws it as though there is a big band from the inter aspect of the IGHL and the posterior aspect of the IGHL, and that structure does not exist. There is no band there, and there's the edge of the IGHL, which we call the IGHL, but is just really the leading edge of it. This has actually been really carefully studied. This is going to sound crazy, but Devsky got like an entire R01 grant to study the IGHL and produce like these 5 biomechanical papers. And one of them literally just shows, he examines the mechanical characteristics of the entire IGHL, and there is no change. Like, it has the same stiffness, the same thickness, the same failure schedule throughout it. Does not have a greater amount of the failure at the front or at the back. So it's not, there is no IGHL. There is just the IGHL. There's one continuous structure that is of equivalent thickness.
Interesting. This kind of shows that a little bit. So this is looking at glenohumeral translation. So, obviously you can grab a shoulder in somebody that's relaxed and move it around. So there's a little bit more A to P translation, but as you kind of bring your arm up into around 30 degrees of abduction, that's where you have maximum capsular laxity, and that's where maximum translation occurs. So real quick, we got a couple minutes here. I wanted to go through my shoulder exam, and Peter, you can chime in if you have any other specific things, but how I look at the shoulder. So, like any other joint, inspection, palpation, range of motion, and then I'm looking at more specific testing. So cuff, biceps, and stability. So the way that I do this in my head, and again, you guys have done this for a couple of years now, and you've done this for about a year, I guess, maybe more in med school. It's easy to just kind of go through the motions sometimes and say, like, okay, I did O'Brien's test and it hurt, but like O'Brien's test makes everything hurt, so you have to really like check off pathology as you're going through the exam, so that you can narrow things down, so that if you have advanced imaging, or if you need advanced imaging, you know what you're doing, right? And there's a gazillion different tests. So I'll tell you sort of how I do my exam. So first, anybody that comes in, new patient with shoulder pain, you really need to look at their neck. What this means for me, a lot of this is just asking them, do you have neck pain? Neck pain on its own doesn't really help a ton, but do you have pain that radiates down the arm past the elbow? If it goes past the elbow, it's probably not a shoulder pathology type issue. If it radiates to the elbow, it could certainly be shoulder pathology. And then you can check neck range of motion. and you can do a Sperling's maneuver, which I've never been great at. But if they say like, oh, I move my neck like this and I feel pain that shoots down my hand, obviously you have to think about the neck problem. Then ask about concomitant numbness, tingling. They could be complaining of a ton of shoulder pain, but they're like, you know what, but like certain times a day, I have numbness tingling goes down the hand, which can obviously be from peripheral nerve issues as well. And then isolated weakness is something to keep an eye out for as well. So shoulder exam for me, for a new patient, I really try to have, shirt off or gown on so that I can actually see their shoulder and look for pathology. And you can see subtle atrophy or not subtle atrophy, I guess, by just looking at somebody, and something to keep in mind, especially as you're starting out. And then look for prior surgical scars. You'd be amazed at how many people will say like never had surgery on their shoulder, and then you see some portal sites there. So palpation wise, I think this is somewhat helpful. I don't think it's particularly helpful. I think people put a lot of especially like from an insurance standpoint, put a lot of weight on this. But I will start by having somebody a lot of the time say one finger and point to where you have pain. They point to the front of the shoulder, then you're thinking, biceps pathology, that sort of thing. They're pointing to outside of the shoulder. That's one thing. If they point to the top of the shoulder, you think AC joint. That can be really helpful. And then I'll push on the SC joint, I'll push on the AC joint, I'll push on the bicipital groove. A lot of those areas you push on the biceps groove, it seems like it hurts in everybody that has shoulder pathology. So I don't know if it's particularly helpful, but it's another, data point when you're doing your examination. And then periscapular muscles, you can really kind of, if you have somebody come into internal rotation like this, you can feel under the medial board of the scapula, and a lot of times they'll have point tenderness there. So range of motion, to me, this is extremely important, and doing a good range of motion test, I think, is very important. So what does this mean? I'll start with active range of motion first. So I have them do it. For me, I have them doing this standing up, not sitting down, standing up. So forward elevation, abduction, external rotation, internal rotation. If that's normal, then I kind of move on with my exam. If it's not normal, and it depends a little bit on the pathology, but I'll usually have them actually lay down, and then I'll do supine passive motion so that their scapula is stabilized, as I kind of said there. And we'll go a little bit more into that here. So just briefly, so if they have normal, say they come in with shoulder pain, they have normal range of motion, actively, I mean, it could be a lot of things. There's a lot of overlap in between these, but, biceps, labrum, that sort of pathology. They have abnormal motion. If it's just active motion that's abnormal, then it could be a nerve injury, but you're kind of thinking rotator cuff. If they have abnormal active and passive range of motion, you're thinking arthritis or adhesive capsulitis, and that's where your X-ray comes in. So you can help with this by holding the scapula to help isolate monohumeral motion. As I kind of mentioned here, so adhesive capsulitis versus arthritis, their examination can be very similar. So I do use this in a lot of patients. So I'll check their end range of motion. So like I'll just take them into external rotation. If they've got a lot of pain there, that's like a capsular problem, a capsular pain problem. If they have pain when I do that, and abduction and forward elevation and internal rotation, it's like fine. And then you get to that end range of motion. To me, that's adhesive capsulitis or arthritis, most likely. And I do think that's a really helpful test. And then to tell between those two, you need an X-ray. Something for throwers, well, I guess for a lot of people, but especially for throwers, checking for posterior capsular tightness in abduction, and checking from side to side to see if there's a difference can be a factor as far as shoulder pain goes.
We're gonna have a talk on shoulder later on. I think there's some more subtleties than that, but I think it's true. You should measure rotational range of motion and abduction.
At what?
Rotational range of motion and abduction.
Cool. I'll let you go into more detail there later on. In the interest of time, we'll keep moving here. So cuff testing, isolate each of the rotator cuff muscles. So these are just a couple of, I guess, particulars for me. So Job's test is supposed to be 90 degrees of abduction, 30 degrees of, forward flexion, I guess. And you test the cuff. I mean, this is sort of what I've been told, what I've noticed in my exam. So if you do that with the arms up here, you can recruit the deltoid pretty heavily. If you do that more at 60 degrees like this, you're really isolating the supraspinatus a little bit more. And you'll notice a difference. So somebody will have no weakness or pain here, and then you bring them down here a little bit, and you'll actually be able to isolate some weakness from side to side. So I do think that that is a little bit different from side to side. Drop arm test is if you have a big cuff tear and you hold the arm up, it'll fall down. And you do that with the thumb down, so empty can test. Infraspinatus is elbow at the side, external rotation. Again, more of a specific thing. So if you have right here and you're pushing out, you can really recruit a lot of your posterior deltoid. If you bring the arms out into like 30 degrees of external rotation or more, and you try to isolate them there, you'll notice some specific infraspinatus weakness as you push resistance there. So that's how I do those two. Teres minor, form lower side here, but bring the arm up into 90 degrees of abduction, then have them attempt external rotation. If they can't do it or it's extremely weak on one side, you worry about teres minor. For me, this is really, I mean, people don't have isolated teres minor tears. You can have isolated teres minor atrophy, but this is more of an issue if you're looking at somebody and you're trying to figure out, okay, if I'm going to do like a reverse on somebody that has no external rotation down here, is their teres still functioning, or to see how big their cuff tear is exactly. Subscapularis, there's there's probably more tests, but 3 predominant tests here. So lift-off test is what you kind of always learn about. That is only really positive if you have a larger subscap tear. So you have to tear, I can't remember the amount, it's like a centimeter or something like that, but you can still have a normal lift-off test, even with a lot of the tendinous portion of the subscapularis torn. So the belly press test, which is, standing up like this, you have them elevate here and they have to keep their hands flat on the belly. That is more more specific for subscapularis. And the bear hug test is where you basically bring the arm across the body like this, and then you pull against resistance. That's really trying to isolate upper border subscap tears as opposed to larger ones, which can be missed on belly press and lift off. Impingement, this is, for me, I'll do the Hawkins maneuver. It's really more just to see if they have pain related to the cuff. I'm not a huge believer in like isolated impingement, but cuff pathology secondary to impingement will be isolated with that Hawkins maneuver there. Biceps exam, so tenderness over the groove. Again, like I said before, this is not super specific. A lot of different pathologies can have tenderness there, and it's sort of just a sensitive area if you push on your own bicipital groove. Speeds test, really what I'll do with this is, I'll check their supraspinatus strength, and if they're like, that doesn't hurt too much, then they go like this with palms up, as you can kind of see there, and they have a lot more pain there than I'm starting to think biceps in my head. And then Jurgensen's test, I haven't found to be particularly helpful, but again, when I'm concerned about biceps pathology, I will do that. And I'll do it with the elbow a little bit more extended to isolate the long head of the biceps. The way that I do is I have them keep their palm up and then try to resist me in supination. AC arthritis, so tenderness over the AC joint is probably still probably the best way to look at this. You can also see if what I'll kind of do is have my hand over the AC joint and then have them move the arm into crossbody adduction and say, does it hurt here when you do that? And if they do, then you think that this is probably AC related. Pain with overhead activity as well. And then last couple slides here. So slap tear, this is hard to diagnose. I mean, sometimes it comes in and it's pretty classic. I think imaging has made slap tear, or I guess made slap tears a big thing maybe 20, 25 years ago. Not sure how much of that is pertinent anymore because the superior labrum is meant to be mobile. And there's a kind of a variety here, but there's O'Brien's test where you kind of cross the body, thumb pointing down, and then resist it. Like I said previously, that hurts with like almost every shoulder pathology. You're supposed to feel like a pop or a click or something. The Mayo shear test or shoulder shear test is probably a little bit better. And so basically how you're doing this is you have them in abduction, external rotation with a little bit of a forward press on the back of the shoulder. And then you bring them kind of from, full abduction down to about 90 or 70 degrees or something like that. And then what you'll actually feel for people is as you come down, there will be like a snap or a pop and they'll be painful. Again, that's positive test. And then stability. So a couple things here, the Gauge sign, I don't remember exactly how you say that, but so that's looking for inferior capsular hyperlaxity. And this is really something that you're comparing side to side. And what you'll do is you can kind of see here is you put your hand or your forearm on the top of the shoulder, and that'll hold the scapula stable. And then you bring the elbow up so that the shoulder's going into abduction. Then you check from side to side. And if there's a significant, if it goes up a lot higher on one side versus the other, then you're worried about hyperlaxity, inferior capsular relaxity. Oh, yeah. Okay. That's a good point.
So you can have a normal.
And anterior apprehension. So I don't know how you do this exactly, but how I'll do this is I'll have them laying down and I'll bring them near the point of instability. So abduction, external rotation. Then I will give them a relocation maneuver. So I'll kind of hold them reduced with the posterior force and then hold them into that position and see if they feel okay. And then slowly start to take pressure off. And then for me, that's been easier to tell when they have that apprehension, right? Because they're like, oh, no, don't do that. So that's how I'll do it. I don't know. You see a lot more of this than I do. So
I usually bring them up and say, does this make you nervous? And then I push back on the head. Does that make you feel better?
Yeah.
There's theoretically a third one where you then immediately remove your hand. Patients, that's called the surprise sign. I do not recommend that one.
Yeah. I mean, I don't know if you've done, I've never done this, but you can dislocate somebody in clinic. So just do it, especially in somebody that's had a recent injury, just do it carefully and quickly. I think that's 7 o'clock, but posterior instability is posterior load and shift, where you basically hold the load on the glenoid and then you shift it anterior posteriorly. Kim's test and jerk test. I basically what I'll do with this is I do this laying down. I think technically you're supposed to be standing up and supporting the scapula, but basically we'll load the shoulder and then bring them into come across the body with a posterior load and the arm in a little bit of internal rotation, and then see if there's a clunk. Or really for me, if there's a lot of pain as they do that, especially as they say in the posterior shoulder, I'm starting to think of posterior labral pathology. I haven't had a lot of luck with actually feeling a clunk there, but you might have more nuances with that than I do.
I've definitely felt a clunk. I mean, I think the one thing about this test, and this is also true of the subscapularis test, it requires a patient that has good internal rotation motion.
That's
So
true.
if you have stiffness internal rotation, or a patient who's not willing to bring the arm in internal rotation, you will not be able to test better than pushers to the knee or the subscapularis.
And then last slide here. So hyperlaxity, just something that you should always really be looking at in instability patients, right? Also people that have sort of vague pain, and kind of the idea in my mind is if the capsule is hyperlax, people can have, they're on this like edge, right? Where they do something and it kind of pushes them over this edge where their shoulder is no longer functioning and stable. And that's where PT comes in. I guess we'll talk about this more later, but so look at a Baden score, look at the other extremity. Anytime you're talking about instability, you should probably be doing this at least early on. Sulcus sign, you can kind of see here with the arm in a little bit of basically neutral internal rotation. You don't want it to be completely externally rotated because the subscapal tension in the shoulder. You just pull an inferiorly directed force and you see if they develop a sulcus there. But we'll talk about that more later in the year as well. Cool. Any questions? Sorry, I went a little bit over there. This is so ridiculous.